All right, thanks guys. Welcome back. We're going to get started back from our lunch break today. I'm Will Hitchcock. I'm with Washington State Department of Health, the Injury Violence Prevention Program. I'm the Regional Network Coordinator, and we are partnering with Harborview to put this event on today. And so we've got a few more sessions this afternoon. We've already had some great sessions this morning. So we are glad to have you back with us for our next sessions. And so we've talked about a lot of topics so far, and now we're going to move into a topic on rehabilitation. And so we have with us Dr. Fuentes. She has attended college at Stanford University and medical school at the University of Michigan. She completed her physical medicine and rehabilitation residency and served as chief resident at the University of Washington in 2012. Then, after finishing a clinical fellowship in pediatric rehabilitation medicine at Seattle Children's Hospital in 2014, she went on to complete the Pediatric Injury Research Program Research Fellowship at Harborview Injury Prevention and Research Center. Dr. Fuentes is now an acting assistant professor with the University of Washington, Department of Rehabilitation Medicine, and with a clinical practice at Seattle Children's Hospital. Dr. Fuentes' research focuses on health disparities and the cultural context of disability and rehabilitation interventions. And her long-term goals include using stakeholder-engaged research methods to deliver culturally appropriate rehabilitation interventions to American Indian and Alaska Native children with functional impairments. And so at this time, I'm going to go ahead and turn that over to Dr. Molly Fuentes.
Hi, good afternoon. As you can read, I have no disclosures to report. And these are the things that I'd like you to be able to learn from our time together. So being able to differentiate between different rehab team members and the levels of rehab service, being able to describe common functional impairments after moderate to severe traumatic brain injury, identify some outcome measures that are used in pediatric TBI, and then discuss some long-term functional outcomes. Here's the order of how we'll progress. And this is the classification system or the framework that really underlies rehab practice across all of the disciplines involved in rehabilitation. It's the World Health Organization's International Classification of Functioning Disability and Health. And basically what it says is that there's any health condition can cause a change in the body function and structure, such as for brain injury, it can cause changes in your thinking or changes in the way you move, which then affects your activities, the way you walk, the way you talk, the way you communicate, which then affects the way you participate in your desired life activities. And all of these are influenced by the environments that you come from and then the personal strengths and challenges that you have within your life. And so what I think is nice about this is it really shows that disability is a social construct, and it very much depends on the context that a child is coming from. And overall, the goals of rehabilitation are to restore function as much as possible. That can include neurologic recovery, where the weakness improves to where the child is full strength or where there's no more cognitive impairment. But sometimes it means compensating for the deficits that are still present. And that involves overcoming both the environmental and social barriers that prevent the child from participating fully in the way they want to. Our goals are to prevent or reduce secondary disability, so contractures, skin ulcers, etc. And so that the children can participate in their desired activities. And unlike adult rehab, where you try to get the person back to where they were before their injury, for children who are aging and should be continuing to develop, we need to help them continue to meet their developmental milestones. So rehabilitation services happen across a variety of locations and throughout the spectrum of care after the brain injury. And so the first location that children receive rehab services is in the acute care hospitalization. And the goal at this time is for the child to maintain their body structure so they don't have joint contractures, so they don't get skin wounds, so that they're ready to start rehabilitating once they've had more medical recovery. So this is making sure that the child is positioned correctly and that they're getting their stretching or range of motion. It's mobilizing the child as early as is medically possible, using strategies to improve their level of arousal or awareness, and then assessing if the patient needs ongoing rehab services when they're medically ready for discharge, and what location those ongoing rehab services should happen in. So for the post-acute rehabilitation, there are several options. One option is outpatient rehabilitation if the child is safe and ready to discharge to the home environment. And these outpatient rehab services can happen at a clinic or within the school setting. These rehab services usually happen only once or twice a week for each discipline. There's home health rehabilitation therapies, and the caveat with this is that the child is supposed to be homebound or unable to leave their home environment for medical reasons. There's also the possibility of having post-acute rehab services in a skilled nursing or a subacute rehab facility. For somebody to qualify for this, they would need to have skilled nursing needs, and there's really a variable access to rehabilitation therapies. You know, some settings would have a daily therapy at a lower intensity, but some it's even less frequent than that. And so what I have the most experience in is inpatient rehabilitation. And there are several regulatory and compliance issues that guide who gets to be a candidate for inpatient rehab. And the kind of most well-known one is that the child needs to be able to participate in 3 hours of physical therapy, occupational therapy, and or speech therapy daily. And then in addition to those 3 hours of the core therapies, they have additional therapeutic recreation, rehabilitation psychology services, and school services, and all of these are under the oversight of a rehabilitation medicine physician. When a child arrives at the inpatient rehab unit, there's a patient-centered evaluation that's multidisciplinary in nature, where goals are set to address that individual's impairments and their needs in the setting of their own personal, environmental, and social context. There are weekly meetings with the family and the rehab team to discuss the child's progress and the plan for what needs to happen for them to achieve their inpatient rehab goals. We track a child's functional progress from admission to discharge to make sure that we're remaining on track as they move towards their goals. And then a big part of inpatient rehab is actually the planning for discharge. And so there's a lot of coordination that goes on, both getting the necessary equipment in place for the child to use at home, to get outpatient rehabilitation therapies identified and scheduled for the child, along with the communication that goes between the inpatient rehab team and the outpatient rehab team, and then getting the child ready to return to school. And so this involves different levels of cognitive testing, either administered by the rehabilitation psychologist or the speech therapist, and then in conjunction with the school teacher, identifying what supports need to be in place in the child's school environment to help them continue to be successful in their learning. Whether this is returning to their previous learning environment or with modifications or such as placement in a special education program or 504 plans. So inpatient rehabilitation for children can happen at a variety of facility types. So it can occur at children's hospital-based inpatient rehab units at general hospitals, or at rehabilitation hospitals. And some of those rehabilitation hospitals have pediatric-specific units. What's important about this is that work has been done by other faculty at the Harborview Injury Prevention and Research Center, identifying that there are indicators for inpatient rehabilitation for pediatric TBI that show what's needed to provide quality rehab services for children with brain injury. And there's differences between rehab facilities at children's hospitals, pediatric specific units in the general hospitals, and how many of those indicators they can meet. And the type of rehab facility does matter. So children's hospitals have more efficient rehab admissions compared to rehab that occurs at general hospitals or rehabilitation hospitals. Though the rehabilitation hospitals that have the pediatric specific units would be expected to have efficient rehabilitation admissions as well. So now we're going to move on to talking about the rehabilitation team. And the team is going to be presented in no particular order. Just because you're listed, later in the team list doesn't mean you're of less importance to that child's rehabilitation process. So the rehabilitation team includes physical therapists. Therapists work on the child's gross motor skills, the strength of their legs and their flexibility, and then their overall mobility. So the way they move from one position to another, and the way they move from one place to another, whether that's by walking or using a wheelchair. There are speech therapists or speech language pathologists. They work on communication and language skills, both receptive and expressive. They address memory and thinking skills, following directions, being able to do things in the proper order. And then they also work on swallowing for children with brain injury who have changes in the coordination of the muscles of swallowing that to make it so that they're safer to eat food by mouth. Occupational therapists address self-care skills. So these are the sorts of things that you have to be ready to do during the day. So getting dressed, going to the bathroom, bathing, eating, etc. They address the upper extremity strength, the coordination, fine motor coordination for the child, and they really incorporate both the motor skills being worked on in physical therapy and the cognitive skills being worked on in speech therapy. Rehabilitation psychologists are also important members of the rehabilitation team. So they address behavior, so the agitation, anxiety, depression, confusion that a child might be having, coping and adjustment to the functional changes and the hospitalization. This is both for the child and also the parents and family, which is, they're a very important team member for making sure that the family is being well supported. And then, at least at Seattle Children's Hospital, the rehabilitation psychologists are also neuropsychologists, and they do the testing that helps quantify the child's cognitive strengths and deficits. School teachers are very important parts of the rehab team. On the inpatient rehab setting, they work to assess the child's academic skills. They provide ongoing instruction in a schoolroom setting, maintain contact with the child's school so that there's open communication between the school and the rehab team. And then they're essential in helping coordinate the school reintegration plan, along with rehabilitation psychology and speech therapy. Social workers are another key member of the rehab team, and they provide support to the family during the child's hospitalization and rehab stay, and help assist with resource identification and help families use the resources that they qualify for. Recreational therapists help during the inpatient rehab setting by working on community integration skills. The most fun way this happens is they do outings with the patients where they practice the skills that they're learning in physical therapy, occupational therapy, and speech therapy on field trips outside the hospital to integrate those skills. They also help the family and child identify the leisure and recreational activities that they might want to participate in the future, and also help coordinate any transportation needs. This is very important for children who need to use wheelchairs or mobility devices after their injury, because not all vehicles are easily modified to accommodate power mobility. Child life specialists also help children cope with a hospitalization, and if there's any painful procedures that need to happen during the rehab stay, they're essential support for that. For older teens and young adults, vocational or rehabilitation counselors are an important member of the planning team. They really help identify strengths for employment and any additional training needs that might be necessary for the child, and help provide a link with the Department of Vocational Rehabilitation. And then we have care coordinators or discharge planners who help coordinate all of the equipment, appointments, and help make sure that the home is ready for the child to be discharged. And then dietitians assist with the dietary needs and healthy diet choices. Rehabilitation nurses help provide ongoing assessments of the child's needs, and they really help encourage the family to incorporate the skills that they're learning on rehab to start making those part of the child's habits outside of those 3 hours of core therapies, so that they're really utilizing all of their available time on the rehab unit. And they also train the family in any necessary medical skills, such as administering tube feeds, giving any medications that are necessary, recognizing seizures, etc. And then finally, there's the physiatrist or the rehab doctor, who's a specialist in physical medicine and rehabilitation. And some physiatrists have additional training in pediatric rehabilitation medicine. And what we do is we manage the medical sequela of traumatic brain injury and help identify any complications that are occurring. We prescribe the equipment or the orthotics, and are responsible for leading and coordinating the interdisciplinary rehabilitation team. Okay, so now moving on to the impairments commonly seen after traumatic brain injury, and the ways that the rehabilitation team might address those impairments. So the first are the disorders of consciousness, or the levels of arousal. And so this is what's happening in the acute care hospitalization. So a child might be in coma still, where their eyes are closed and they're not responsive to their environment at all. In a vegetative state, or another term that's becoming more popular is unresponsive wakefulness. That's where the child's eyes will be open, but they're not interacting or responding to their environment in any way. And then there's the minimally conscious state, where there's inconsistent response to environmental stimuli. Perhaps, a common thing that we hear from families is that the child will open their eyes when a loved one is talking, but not when a stranger is talking. And so the rehab strategies that we use for this are range of motion, exercises, positioning, and orthotics to prevent contractures, structured sensory stimulation, and then medications that are paired with a very systematic and objective monitoring to see if the initiation of the medication made any change in the child's level of consciousness. So the medications that are commonly used are dopamine agonists, and amantadine and bromocriptine are two of the more common, as well as GABA agonists, which are really at the level of case report. There's not a lot of any randomized controlled trials testing that yet. So another common impairment after traumatic brain injury are cognitive impairments. And I think it's very important to remember that communication does not always equal cognition. And so if you're not sure that the child is able to communicate with you, you're not able to fully assess their cognitive level. The common impairments that are seen are deficits in attention, memory, behavior, executive function. So these are things like being able to manage multiple different tasks, to be able to filter your thoughts or your behaviors, to be able to move from one task to another, and general problem solving and organization. And then also your social functioning, which includes your emotional lability, your ability to recognize emotions in yourself and in others, and then responding to social cues. And another important thing to remember is that the extent of a child's cognitive impairment might not be known until they're older, when some of the executive functions would be expected to be developing. So the skills that are required of a of a preschooler who's injured are different than what would be expected, for a teenager, and so they might, grow into their deficits. So the rehab strategies for children with cognitive impairments really fall under the purview of the speech therapist and the rehabilitation psychologist. And so they are, except for this one, for arousal and attention, that's where the physician gets involved, and we might prescribe some medications to help with those. For memory, that's working on your external memory devices, your organizational strategies, your general compensatory strategies. And then for executive function, behavior, and social functioning, it's very important to have a structured environment, to have choices available to the child. And then there are existing family training modules that have been evaluated in the literature that show a lot of promise for helping families cope with these behavior changes after discharge from inpatient rehabilitation. So the motor impairments that happen are weakness. So this could be focal weakness from, a targeted location in the motor strip of the brain. And you can see that the brain is, we call it somatotropically organized, so that there's certain spots that represent different parts of the body. It could be generalized weakness, and sometimes the weakness can be from deconditioning. If the child was laying in bed for several weeks, they're going to lose some of their strength. Their coordination and balance can be impaired. Apraxia is where the strength is intact, but the motor planning, the impulse going from the brain to the limbs to move is impaired, and so the children aren't able to initiate the motor plan. And then hypertonicity, or problems with muscle tone. So there's spasticity, where the muscle contracts when it's stretched. Dystonia, where the muscles or limbs take on different postures because of the muscle tone. And then muscle rigidity. And so these are addressed often with physical therapy. And so they get therapy for strengthening, motor retraining, mobility training, adaptive equipment trials, and family training. We prescribe orthoses or braces to compensate for weakness. For apraxia, it's really focusing on the motor retraining, the repetition of the motor activities, and cueing. And then for the muscle tone abnormalities, stretching and orthoses are common first-line treatments, but often children will require medication such as baclofen, which can be given orally, or in some cases through an intrathecal baclofen pump, benzodiazepines, onabotulinum toxin or Botox injections, phenol injections, or other medications. There are sensory impairments after brain injury. So some of these are tactile, meaning that the feeling over the area of skin is impaired, or proprioceptive, meaning that you're unable to tell where your joint is positioned in space, or where your body is in space, which can make it hard to do tasks without looking at that body part. So this is where occupational therapists help a lot. And so they work on cueing and retraining of different activities to compensate for that loss of sensory input. And one important area that this happens is for safety. If you have a temperature, if you have an area of lack of sensation in one part of your body, you should be checking the temperature of your shower with an area where you have good sensation. You can also lose your sense of smell after brain injury. And there's nothing that you can really do to make the sense of smell come back. And so it's a matter of making adaptations to compensate for that. So increasing the flavor in your food, for safety issues, compensating with your other senses to identify gas leaks or spoiled food. And just being aware that sense has changed. You can have changes in your hearing. And so it's important to have an audiological evaluation and get hearing aids if appropriate. And then to work with your speech therapist on compensatory strategies. And some of these involve making sure you're placed in an appropriate position for conversation, and that you're trained in nonverbal communications as well. You can have changes in your vision. And so some of this could be as simple as getting corrective lenses to improve your acuity. But if you have a field cut or neglect, meaning you either can't see in one half of your visual field, or you're not able to attend to one half of your visual field, you'll need to practice your cueing and training strategies so that you will then move to attend to the area that you're neglecting before. You can have double vision, and so for this you would use an eye patch, prisms over the eye, and then sometimes even a surgery to correct that. You can have communication impairments. So aphasia is the kind of the inability to create verbal speech. Dysarthria, where you're not articulating the sounds appropriately anymore. Apraxia of speech, you're not able to initiate the motor movements required for speaking. And then you can also have an impairment in your communication as the result of other impairments, because you're not hearing well, you're cognitively impaired, and so it makes it hard for you to communicate in the same way. And so the main strategy for this is the speech language pathology to work on compensatory strategies. And then the medical sequelae that we're watching for are autonomic dysregulation. So this is more common in the acute phase, where you can have blood pressure instability, temperature instability, and high muscle tone. Heterotopic ossification is where the body starts laying down bone in areas that aren't where there's not supposed to be bone, and so it can lead to problems with range of motion and comfort. We watch for endocrine dysregulation. So the pituitary gland is in the middle of the brain and can have a problem. And then the common things that we treat are post-traumatic headache, post-traumatic epilepsy, post-traumatic hydrocephalus, where there starts to be more fluid and pressure in the brain, and then sleep disorders after brain injury. So now we're going to move on to some outcome measures that are used in pediatric traumatic brain injury. So the important thing to remember here is that measures can either look at capacity, so what the child's able to do in an ideal environment, kind of the peak of what they would possibly do, versus their performance, which is how they behave or act or achieve that skill in everyday life. And then measures can either be self-report, where the child gives you information, parent report, where the parent gives you information about the child, or provider assessed, where the provider rates the child objectively. And there are common data elements for pediatric traumatic brain injury so that we can compare findings across research studies, but also across different sites of clinical care. And so important things that we watch for are the date and mechanism of injury, the initial Glasgow Coma Scale, the duration of the child's loss of consciousness, their time to follow commands. So when they're able to, if you say, raise your right hand, they raise their right hand. The duration of their post-traumatic amnesia. So when a child's in post-traumatic amnesia, they'll be awake and they'll be interacting with you, they'll be communicating perhaps, but they won't be laying down new memories. So we test that with either the GOAT for older teens and young adults, or the COAT for children who are 3 to 15 years old. I'm going to move through these ones rather quickly so we can get on to the rest of the talk. And so there's global outcome measures, such as the Glasgow Outcome Scale. To look at adaptive and daily living skills and physical function, rehab units often use the Functional Independence Measure for Children, or the WIFIM, or the Pediatric Evaluation of Disability Inventory to track the child's skills. The WIFIM measures 18 different items in 6 domains and is scored from 1 to 7. So where a score of 1 means the child requires total assistance in that area, and then a 7 means they're completely independent in that area. And there are age norms for this. And then, as I'd mentioned before, participation is a very important part of rehabilitation. And so the measures that we look at for that are common data elements include the child and adolescent scale of participation, the social functioning scale of the PD, and the strengths and difficulties questionnaire. The family environment is very important, and so we might use the family assessment device to identify strengths and challenges in the home environment. And then moving on to functional outcomes. Disability has been found to persist among children who are hospitalized for traumatic brain injury. So this was a study by Dr. Rivara. And at 2-year follow-up, the children had improvements, but they were still impaired with reductions in their quality of life, participation, and an ability to care for themselves. And the households with higher incomes those children had higher quality of life. Inpatient rehabilitation for pediatric brain injury does improve a child's functional independence. But even among the kids who go to a rehab unit, there are differences. So Medicaid insurance was associated with lower function at discharge. And those children who received rehabilitation at children's hospitals had better cognitive scores on discharge to the home environment. Brain injury that's sustained during early childhood has an effect on the child's daily functioning, even many years after the brain injury. So this was a study that found that children who were between 3 and 7 when they were injured had impairments in their daily activities 7 years after brain injury. It's not surprising that the more severe brain injury was associated with poorer function. And the parenting practices and the home environment moderated that relationship between injury severity and function. So parenting styles that were either most permissive or most authoritative, and those children from less advantaged home environments had amplified adverse effects from their brain injury. And in a cohort of children who were hospitalized for brain injury, the majority of them at 1 year after their injury had physical and cognitive impairments. But only 39% had received injury-related outpatient services. There's definitely a disconnect between that level of impairment and who's getting services. And in conclusion, pediatric brain injury is associated with impairment across multiple domains. It can result in long-term disability and an impact on the child's daily function. A multidisciplinary rehabilitation approach can improve that child's function. But a minority of children hospitalized for brain injury receive outpatient rehab services despite the presence of impairments. So I'd like to open it up now for questions. I pushed the wrong button. Okay.
Yeah, so just you can open up the Q&A.
Thank you. Should I check the chat to see if it's in the chat?
Yeah, I was just checking.
Okay.
Looks like there was just one.
So one of the questions is, are there parenting classes to help the parents adjust to the disabilities? That is something that's addressed during the inpatient rehabilitation period with the rehabilitation psychologist. Some of the classes do focus on how a parent might need to adapt to the the change. There have been some studies of the triple P parenting program. So I think it's the positive parenting. I forget what the third P is right now, that has shown that classes in that triple P parenting can improve the family function and the relationship between the parents and the child with brain injury after that. And then there's, at the research level, the development of a computerized module training where the parents and the adolescents together go through the modules and work on activities that have been, and that module set has been shown to improve the parent-child relationship and the family function after brain injury. Another question is that in many instances, children with traumatic brain injury aren't yet ready for the intensity of that acute rehab. So meaning they're not ready to participate in the 3 hours of therapy a day, or for other reasons they're not medically ready. And so a lot of time is lost waiting. And the question is, what do you suggest to families to bridge the gap of services, especially in a rural area? That's a very, very challenging question. And I think that the way rehab services are organized and compensated for doesn't always capture or meet families exactly where they need it, because they might be ready to discharge from the acute care hospital, but like you said, they're not ready to go to inpatient rehab. You know, if they're safe to be in the home environment and the family has the structure in place to be able to care for them in the home environment, you know, that's a place where home health therapies might be well deployed, where the therapist comes into the home setting to do the therapeutic activities and then teaches the family about the exercises that they could be doing to help their child. And then monitoring for when that child is ready to be kind of moved to the next level, or the more intense, the intensity of the inpatient rehab service. If home health therapies aren't available, this is where the burden really does fall on the family. You know, and I feel like that's an area where the rehab services, you know, should be where we need to make more innovations on our end and think about how we can deliver those services better to families, whether that's through better telerehabilitation or other, you know, kind of training the family to provide those services at that time. But there's not a great solution right now. So the next question is, what resources would you recommend for the multidisciplinary outpatient therapy team who are responding to the child who hasn't been able to get inpatient rehab services? And so I think the first question for that would be making sure that they've been seen by a rehab doctor who can do the evaluation and kind of help make that argument that inpatient rehabilitation is needed. If they've been seen by a rehabilitation physician, and that physician thought that the child wasn't ready or there was some disagreement, I think that's the time to, you know, to reach out and have a communication, whether that's a virtual, you know, team meeting where, you know, people participate by phone, and talk about what the barriers are for that child getting the inpatient rehab services and what potential strategies there are. So another question is, given that CMS or the Medicare and Medicaid guidelines do not require a 3-hour rule for pediatrics, what is Seattle Children's criteria for admission to inpatient rehabilitation? So this question, we still do like the children to be able to participate for 3 hours if they can. The main thing that we're looking for is that the children are able to make functional progress in a way that they wouldn't be able to achieve at different levels of rehab services. And, you know, since a child is, you know, existing within the structure of their family, sometimes that means that they're doing rehab for family training, where the family is the one that's actually participating in the 3 hours of therapy a day. The challenge with that is, you know, sometimes inpatient rehab is the right place for the family training to happen. Sometimes that can be achieved just as, you know, can be achieved effectively at a different level of service as well. So another question is, what child-friendly materials do you use in your practice that make a difference with child motivation and participation? So I would say that this is where the therapists who have additional training or additional expertise in working with children really make a difference. I think this is one of the places that would moderate the difference that we saw between rehabilitation at children's hospitals or pediatric specific units and the rehabilitation that's happening at units that don't have a pediatric focus, is that they don't have those skills and that knowledge of child development about how to motivate children. And so, you know, it's trying to make therapy not seem like therapy, but like a game or something that's fun that the child wants to participate in, so that they're continued to be motivated by that. And this is where I feel like the rehab nurses are also very important, as they, since they spend a lot of time with the family and can help the rehab team identify how the child is best motivated, because we all respond slightly differently. And the rehabilitation psychologists also serve this need as well, in doing some in-depth work with the family and child to help them identify the best way to participate. Okay. Okay. Well, I think that's all of the questions for right now. Thank you very much for participating.
All right, thank you, Dr. Fuentes. All right, we're going to take a short 5-minute break as we switch out speakers. So we'll be back with you in just a few minutes.